the video working? Thank you for that, Carissa. And just as everyone filters into the room, I'll say a big thank you and a welcome to Gateway's Season 5, Episode 9 of our regular lecture series. And with that, I'll hand it over to Dan. Take away.
Thanks, Jay. Hello, and welcome everyone to Season 5, Episode 9 of Gateway Center of Excellence in Rural Health's virtual lecture series. Today is April 1st, and our topic is zombie ideas in the emergency department. Not an April Fool's joke. My name is Dan Stringer, and I'm the chair of the board at Gateway Center of Excellence in Rural Health, located in Goderich. Gateway Center of Excellence in Rural Health is a community-based, not-for-profit corporation that aims to promote the health and quality of life of rural residents through research, education, and communication. Waiting a long time for emergency care might seem like an ironic statement, yet increasingly people have been experiencing longer and longer wait times in the emergency department to get care. There have been some emergency rooms in Ontario reporting wait times as long as 15 or 16 hours. And these long wait times have consequences. And as an estimated 1 in 5 Canadians don't have a family doctor and rely on emergency departments to receive care, we can only expect that this situation may not improve soon. To help understand the issue, the speakers today are Dr. Ken Milne and Dr. Kay Dingwell. Dr. Milne is a staff physician at the Strathroy Middlesex General Hospital in Strathroy, Ontario. He's been doing medical research for 41 years, publishing on a variety of topics. Dr. Milne's been working clinically for 30 years, and he's an associate professor at the Schulich School of Medicine and Dentistry at Western University. He's the creator of the Knowledge Translation Project, The Skeptic's Guide to Emergency Medicine. Dr. Kay Dingwell is a rural emergency department physician at Prince County Hospital in Summerside, PEI, a community of 15,000 people. She has a lifelong love of rural living and feels strongly that all Canadians deserve to get the care they need when they need it, as close to home as possible. And we all echo that. To thank those that are ongoing attendees, we offer certificates at the end of each semester to those with perfect attendance to recognize your commitment to and involvement with this educational series. Throughout the lecture, we do encourage you to ask questions of the lecturers and the panelists and add your questions to the Q&A box as you wish, and they will be addressed. So with that, I'm going to turn this over to Ken and Kay, and we'll join you when the lecture is over. Take it away, Ken.
All right, well, I will share my screen, and doing that, I have to pick a way to do that, and so I'm going to the advanced settings on my computer. I'm going to share the screen. And maybe I'm not. Sure I am. All right, and then I'll start the slides. All right, everything okay there, Dan? If you give me a verbal, because you're on mute.
Looks good to me, Ken.
We are good to go. All right, so as Dan said, and I'm kind of a little disappointed, Dan, that you didn't show up in zombie makeup. I was expecting you to like be blah, coming towards us, wanting to eat brains. But this is not an April Fool's Day joke. This is after noon hour, so April Fool's is officially over. So we're going to be talking about some really serious things. And specifically, we're going to be talking about zombie ideas about emergency department crowding. So I know some people might be going, hey, what the heck is a zombie idea? Well, it was coined and defined by an economist named Paul Krugman in 2013. in a New York Times article. And he defined a zombie idea as one that is a view that's been thoroughly refuted by mountains of empirical evidence, but nonetheless refuses to die, being continually reanimated by our deep-held beliefs. So a zombie idea in emergency medicine is an idea that just won't die, despite decades of evidence. And every time we think we have killed this idea, this zombie idea of emergency medicine, it just comes back alive again. And so this idea is going to focus specifically on crowding. And so I want to define crowding. And crowding has been defined by the Canadian Association of Emergency Physicians, as well as the American College of Emergency Physicians. They're very similar. CAPE says crowding is a situation where the demand for emergency services exceeds the ability of an emergency department to provide quality care within appropriate timeframes. And ACEP says ED crowding occurs when the identified needs for emergency services exceeds the available resources for patients' care in the ED, hospital, or both. So what is this zombie idea? Well, one of the zombie ideas in emergency medicine regarding crowding is that it's the non-urgent patients who are responsible for crowding. If we could just get all these non-urgent patients, if they weren't in the emergency department, then emergency department crowding would just all go away. Well, this is a zombie idea. And to drill down a little farther, a zombie idea is that if you divert these non-urgent patients, and typically through blaming, shaming, posting wait times to encourage them not to come, telling them to go somewhere else, like, why aren't you in your primary care clinician's office? Why didn't you use a walk-in clinic? Did you know pharmacists in many jurisdictions can treat urinary tract infections? How about telemedicine? All of these things. They think if we divert patients from the emergency department, crowding will be solved. This is something I like to call the diversion danger. Diverting non-urgent patients from the ED will end up missing some sick patients. I know my colleague will confirm that patients do not arrive to the emergency department with a label on the forehead saying, hey, this is heartburn, or no, this is a heart attack. They arrive to the emergency department with symptoms like, I've got some indigestion, I've got a little pain or pressure in my chest, I feel a little short of breath. It would be so much easier if patients would just come in with their diagnosis on their forehead, but they don't. And if you divert these non-urgent patients from the ED, the emergency department will still be crowded. It doesn't fix the crowding problem. It doesn't address the underlying major problem that is responsible for crowding in the ED, i.e., it's ineffective. It doesn't work. And on top of all of that, it's not patient-centered. The patient declares whether it's an emergency or not. Dr. Dingwell and I have years of experience between the two of us, and so what we think might be an emergency may not be what the patient thinks is an emergency. And what the patient thinks is an emergency, that, let's say, sore throat, they think it's really, really important. And so they think it's an emergency. And that's why we're there in the emergency department to assess people to make sure that that sore throat isn't an emergency, isn't one of these terrible medical conditions. And so to put a very fine point on this zombie idea, diverting or fast-tracking someone with a sore throat, like putting them in what we call the green zone or the RAS, the rapid assessment zone, or having a nurse practitioner, a PA, or a pharmacist see these patients, does not get that elderly patient who has fallen and broken their hip who is stuck in the emergency department with no inpatient bed, it doesn't get that patient a bed anytime sooner in the hospital. And so what we have in the emergency department is something called an emergency department compartment syndrome. The ED is the only part of the healthcare system that cannot and will not say no to people. All other aspects of the healthcare system can decline to see a patient. The ED is the light in the house of medicine that is always on for anyone, at any time, for anything. However, it's become a place for everyone, every time, for everything. Dr. Dingwell and I have become availabilists. We're available. And when you can't see your primary care physician, the surgeon, the psychiatrist, the other specialist, just go to the ED. They'll take care of it. And these issues, even a prescription renewal for your blood pressure medicine, becomes an emergency due to lack of access to care. The front door of the ED is always open. Well, not in some rural places now, but the back door, the inpatient unit, the home care services, the mental health care services, the long-term care services, these are often closed. So this overcrowding, it's not an emergency department problem, but the problem shows up in the emergency department. But it's a system problem, and so we need system solutions. And when we look at the problem, we have a lack of inpatient beds. These are medical beds, surgical beds, intensive care unit beds, mental health beds, long-term care facility stuff. We also have a problem with a lack of access to primary care. We don't have enough family physicians. We don't have enough access to nurse practitioners or pediatricians. And there's a lack of access to home care. Physiotherapy, occupational therapy, wound care, VON, PSWs, all of these things. That is a system problem that's showing up in the emergency department. But there's also a lack of access to advanced imaging, like ultrasounds, CAT scans, MRIs. And so people are often told to come to the emergency department looking for faster access to these diagnostic imaging tests. And in addition, we have pharmacists and EMS providers who have restrictions on what they can do. And so it's not allowing them to participate fully in the system and practice up to the level of their training and more be better at addressing patients' needs. Now, the main reason, here we go. The main reason for ED crowding is often described as a lack of beds. This is a short form, and it's like a saying that you can say, oh, well, we don't have any beds. This is what I like to call the furniture fallacy. Canada has a below average number of beds per 1,000 people and the highest occupancy rate of acute care beds in OECD countries. So it's not a lack of beds. We have furniture. We can buy beds too. But what we have is a lack of staff. And specifically what I'm talking about is we have a lack of nurses and nursing staff to take care of admitted patients. So it's not a furniture problem. It's a staffing problem. And because we don't have the staff to take care of patients on the inpatient side, patients get warehoused on the emergency department side, waiting for hours to days for a bed in the hospital. And this is not just some inconvenience, and I think Dan mentioned that in his introduction. This can be deadly. So you can have delays which are associated with increased mortality. If you hold a patient who's over 75 overnight in the hospital, there was a study published recently in the Journal of American Medical Association looking at almost 1,600 patients, and they found a 5% absolute increase in mortality associated with being boarded or staying in an emergency department overnight instead of getting an inpatient bed. And so this is a reminder. This is a reminder that this can have deadly consequences. And so what do we need? And look at, I use the short form. We need more beds. And what I mean by that is we need more staff to staff the beds. And this is not one study. We have known about delays associated with badness. And I've just put 4 studies up here going back almost 15 years. So we've known for decades that this is a problem. Delays, boarding patients, holding patients in the emergency department can be associated with badness. But, I don't want to focus so much on the badness, but what are we going to do for solutions? I'd like to focus on solutions. I'm more interested in solutions than I am with blaming. And so some of the zombie solutions that don't have high quality, good evidence of efficacy, one of them is triage people away. So you divert people. They come to the emergency department and you triage them away. Studies have looked at this, where patients come to the emergency department and they're redirected, and there's really mixed results. And there is that risk, which we talked about earlier, of missing that patient who has heartburn, but really has a heart attack. And then people have tried to implement these fast tracks in the emergency department. But again, seeing non-urgent patients faster, like that sore throat, like that urinary tract infection, doesn't get the patient with a hip fracture a bed earlier. And if that patient is over the age of 75 and held over in the emergency department for one night, you've just given them an increase of a 1 in 20 chance of dying associated with that delay. And then, of course, other solutions that have been tried, which I would refer to as a zombie solution, is to put a doctor in the triage department. Again, this has mixed results. It can increase length of stay in the emergency department. And Kay and I both work in rural emergency departments. And so rural emergency departments are struggling to have one doctor in the department. We don't have the luxury of having 2 doctors in the department. So how can you have the one doctor sitting up at triage while at the same time they're taking care of patients in the emergency department? So this is not going to work in rural settings. And then one final thing that has been tried that I think is a zombie solution is we'll just make the emergency department bigger. Yeah, let's just add chairs. Let's just expand the waiting room. Let's just make the inner part of the emergency department bigger, so we move the waiting room into the actual department. We don't add staff usually. We don't add a number of emergency physicians to work it. We just increase the tank. And I like to use the analogy of the 401. I assume some people here have driven on the 401, and some people are old enough to have driven on the 401 30 years ago when, let's say, they had 8 lanes going into Toronto. And what have they done? They've added lanes, and they keep adding lanes. And now they're up to something like 16 lanes going into Toronto. Has the traffic gotten better or worse? And in a rural emergency department, if we add lanes, we make our department bigger, maybe we can get the wait times down a little bit. But what that tends to do is encourage people from the urban areas, and I see this in Strathroy. Patients say, oh, well, it's an 8-hour wait at London Health Science Centre, but it's only a 3 or 4 hour wait in Strathroy. And I understand. I think I'll go to Strathroy to get the care I need. But if you make that care faster, quicker, more accessible, you're going to encourage more people to come to the rural facilities who won't have additional resources. And at the end of the day, making that ED bigger and trying to assess those fast track patients quicker, you'll just end up with a crowded highway and the 401 will just get busier. So what should we do? What should we do to address this problem? Well, first of all, don't let the zombie idea dictate policy. We should use evidence-based solutions to ED crowding. And those solutions will have to come from those primary care facilities, from those rural hospitals, those emergency departments around Ontario, where we're talking to mainly people, is that we need to find evidence-based solutions that work in our local centers to address this crowding situation. But you might be wondering, who keeps these zombie ideas alive? Well, I would say there's probably three main sources. One is politicians. Like many other people, they do want to see this solution fixed. We have common ground with them. They care about patients too. But their timeline may be an election cycle and not as long as it takes to fix these solutions or fix these problems. And so they tend to use zombie ideas that may look like a quick fix rather than addressing the underlying problem. We also have administrators who, again, want patients to get the best care, timely care, the right care by the right provider. Their heart is in the right place. Unfortunately, we've put in these control systems for administrators that reward meeting metrics for non-urgent patients. And so you can understand why their focus might be more towards, listen, we've got a lot of people, it's backing up in the emergency department, the wait times are going up, and we're losing funding or not getting our funding bonuses to help support our emergency department. And so we've got to do something about the non-urgent patients. And then finally, I would say the media plays a role at times in highlighting the non-urgent use that tends to shame and blame patients for using an emergency department for their non-emergency problem. And again, I'm more interested in looking at real solutions and less interested in blaming patients for accessing care. So what do we do? Well, I would say stop feeding these zombie myths. Overcrowding is an emergency department issue? No, it's a healthcare system problem. Non-urgent patients are the cause? No. Non-urgent patients take little time and resources. They are not the major part of the crowding problem. And then finally, what's the harm? People have to wait a little longer. They might have to spend a night in the emergency department. At least they're in a hospital. No. Boarding of patients is associated with increased mortality. It can be deadly. And so the best way to finally kill a zombie idea is stop believing in it and fix the system. Thank you very much, and I'm really looking forward to hearing what Dr. Dingwell has to say and add to this.
Well, I'm looking forward to being able to answer some questions about it. So as you've mentioned, a lot of the issues that face rural areas are unique to rural areas and require solutions that have our particular needs, patient populations, and resources in mind, right? Although there's the issue of low acuity patients, those are the simple patients with the sore throat and the minor concern, it seems like a lot of these patients in the ED must be why everyone is waiting so long. But the reality is we see those patients in 5 minutes.
Oh, they're quick, right? They're quick.
Oh, yeah. Bang, bang, bang.
And Dr. Dingwell, why don't in your rural area, why don't they just go to a walk-in clinic? Oh, that's right. We don't have any like the cities.
Yeah, we have maybe 60 hours of walk-in clinic time for the entire province every week. So we can see, about 250 patients through that at about 4 patients per hour. 170,000 people need a lot more than 250 instantly available appointments per week.
And let alone the walk-in clinics aren't there or open. Sometimes your adjacent emergency departments aren't even open. So
exactly.
where are those patients supposed to go?
They are either coming to us or they're not getting care when they need it. They're staying home because we're an hour away from the hospital that most frequently closes. And so particularly in bad weather, which unfortunately we do have a lot of, except during our beautiful summer season, we see these patients then delaying care, hoping that their ED will be open the next day, then presenting to us much sicker, requiring much more intensive care and much longer stays in hospital. Plus, we also see the patients who just go years without any access to primary care. And so when they finally do come into the emergency department after getting their medications refilled over and over with no one ever checking their labs or blood pressure, they're incredibly sick, require a lot more resources, spend a lot more time in hospital and require a lot more complex discharge planning. So these system problems that you spoke to really do snowball into the issues we see in the ED. It's really
So there might be
easy.
some, I was going to say, so there might be some harm reduction going, well, that patient with diabetes or high blood pressure is just coming in to get their prescription renewed for their diabetes medicine or their blood pressure. But wouldn't it be better to renew their blood pressure medicine and their diabetes medicine and check their blood pressure and check their sugar than seeing them 5 years later with a major heart attack or a stroke?
Exactly. The emergency department is the worst place to provide longitudinal primary care, but for a lot of rural people,
Might be
it's
the only.
thing they've got.
Yeah,
So
it's
we're
the
doing a lot
only
of it.
place. Yeah, it's the only place.
It really is too frequently. Around 30% of the patients in my region do not have a family doctor. It's pretty bad crisis. The ones who do, their family doctors are so off their feet with the amount of work they're needing to do to keep the system afloat that it's hard for them to see things that are minor but more acute. So those patients all come to us and they need to be seen. We don't want to just tell them to go home and wait for an appointment in 6 weeks. They still need their concern addressed. That sore throat could be a devastating infection like a peritonsillar abscess or retropharyngeal abscess. These are critically sick patients, but they might not know it. We can't expect the patient to have to be the doctor to decide whether they need to be there or not.
And I tried to put a shout out to all the other members on Team Patient, because the patient is at the center of our care. I'm not the leader of the team in the emergency department. I am on Team Patient, and it's about the patient's needs. And yes, I value having our friends, because, Kristen Watt, who is a pharmacist, is a friend and a fantastic clinician. I welcome her and pharmacists to be involved in care and help with care. Same thing with nurse practitioners, PAs, EMS doing visits and all that stuff. But again, I don't want to lose focus on that. Will not fix the problem in the emergency department of crowding. It may fix some other problems, which is great, access to care, and everybody working on Team Patient up to their maximum level of their ability. But again, that lady with the fractured hip doesn't get a bed anytime sooner if I can divert a urinary tract infection to the pharmacist who is capable of taking care of them.
Absolutely. And of course, our allied health colleagues need to be supported in, as you mentioned, their full scope so that they can order the urinary specimen culture so that they know what they're treating, as opposed to now where often, even though they could do these things, they're not allowed. So it does limit their ability to provide the care that they know how to provide. And so this ends up with patients then coming into the ED because they didn't get a urinary culture, didn't have the appropriate antibiotics because the pharmacist who did treat their urinary tract infection was not able to order it.
But it's not the pharmacist's problem. It's a system problem, and
Absolutely.
the tools and resources that have been, they get their hands tied behind their back. And at the same time, of course, we want well-funded primary care. It is the foundation of the healthcare system to have really good longitudinal primary preventative care so people don't fall off the cliff and land, and then I have to put Humpty Dumpty back together again in the emergency department. I would like them to just step away from the cliff, take a few steps back, but they have to have access to care. But again, we can do both at the same time. We can advocate for robust access and resources for primary care, but that's not going to fix the overall problem in the emergency department, which is a healthcare system problem of we don't have enough beds. We have admitted patients. Half the department sometimes can be occupied by patients waiting for inpatient services. So we need to address that as well. And that's what I really wanted to focus on today.
Oh, half the patients.
Oh, sorry.
in their ED.
Did I underestimate or overestimate?
My 20-bed emergency department has had 30 admitted patients in it. We were still staffed as a 20-bed emergency department. And it's important for people to realize that emergency department nurses, you can't just take a nurse from one department and put them in another and expect them to perform the same job. Nurses are not interchangeable. Nursing is a highly skilled profession. Nurses require training, up-training. They require continuous education to maintain their skills in their fields of expertise. And so expecting all our emergency department nurses to act as inpatient nurses in perpetuity for large volumes of patients well above what they can safely provide care to. We're burning out our emergency department nurses and making this so much worse. They're not being allowed to do the care that they love, that they trained for years, and instead they're being expected to do care without the appropriate supports to provide it. And we're burning them out at incredibly rapid pace. And that's really worsening the situation overall.
And the flip side of that, and it's not the flip, it's an adjacent side of that, is the same thing applies to the physicians who are trained emergency physicians. Now, I know some people do both, but when they're in the emergency department, they're trained emergency physicians and they're expected to do longitudinal primary care. And you mentioned that earlier, they are not the best individual to be doing that. And so we'll see people coming in and they'll have all these questions about primary care, and they're asking an acute care emergency physician for that. And it's like, you wouldn't want me taking out your appendix either. I'm not trained to do that. I'm not the best person to do that. And I shouldn't be advising on long-term diabetes management as well. And yet people come in and go, hey, something's wrong with my plumbing. And I'm like, well, I'm an electrician. I'll take a look, but don't expect much.
Absolutely. And while, especially in rural Canada, the preponderance of our emergency department physicians are family medicine trained, most of us are doing emergency medicine full time. So this is where our skill set builds and remains. So,
as a generalist.
Absolutely. Yeah.
As a generalist. But you're not finding that. You're not finding that in Ontario, where it's a bit of a different situation. We've been having almost 20 years now of a Health Force Ontario program that has a part of that program called the Emergency Department Locum Program, where we're getting emergency physicians now to go to rural communities. And before, you would go to the hospital and you might see your family doctor there, and they could do a punch biopsy for a suspicious mole. They could do a cortisone injection. They could do all of these things that are part of comprehensive family medicine. But now you have some doctor who is a highly skilled doctor from Toronto in emergency medicine going, geez, I haven't done that in 25 years. And they're the ones keeping those, adding some resources to those smaller towns so they don't close, which I hope is better than being closed. But they don't have that comprehensive family medicine continuity, complexity of care sort of background to provide the care that the rural population had before.
Absolutely. And what a lot of people don't realize is, as you point out, urban emergency physicians are not interchangeable with rural emergency physicians. So Justin Morgenstern, even of First 10 EM, said on his podcast that rural emergency medicine skills keep your clinical skills at their peak because we have fewer resources. We're doing a lot more with a lot less. We depend a lot more on our physical exam and our clinical determination skills. We have a lot fewer specialists. We're not looking at the fracture and calling ortho. We're the one doing the procedural sedation while we reduce the fracture and applying the cast and potentially dealing with any issues down the line from that. And then we also just don't have access to what they do. I still have to use what are called lytics for certain types of heart attacks here on PEI because we don't have a cath lab in the entire province. So in most of Ontario, if you were to have a heart attack, you would go to the local place that has a cardiac center and you'd be treated immediately. We don't have that. That's 4 hours away for us. So the way I have to deal with heart attacks here on PEI is completely different from what an urban physician would do. They have no experience doing what I do and managing the complications of it that I have. And so you can't take a doctor from downtown Toronto who's never had to deal with these reperfusion arrhythmias like I do and stabilize them over many hours. The skills are not interchangeable. And so we have to understand that rural solutions need to come from rural doctors and rural health professionals and other disciplines.
So just to put some spaced repetition on what you said and translate that to patient level understanding, if you have a coronary artery, a blood clot, a blockage in your heart, there are two major ways to clear that blockage. The way that we do it now is by putting a catheter all the way into your heart and getting rid of that blockage and putting a little spring and balloon and opening up that blockage. The historic way, going back to the 1970s, 80s, maybe into the early 90s, was to give a clot busting drug which you can think of as liquid Drano. Please do not take liquid Drano if you're having a heart attack. Please do not do that. But it's a dissolvable agent, so it dissolves the clot like it would a clot in your drain. And that's what you're doing in PEI, because 4 hours away to get the actual care that is recommended in 2025. And if you take a doctor who hasn't done that, where they've injected or given or provided or tried to flush that blockage out using that clot dissolving drug, they're not going to be familiar with it. They're not going to handle they're not going to be as comfortable with the potential downstream effects of bleeding and arrhythmias or irregular heartbeats that you mentioned. And so it really is important. You can't just swap out nurses from an emergency department into an obstetrical unit, into an inpatient unit, into a surgical unit. And you can't just swap doctors. Oh, we'll just take this doctor and we'll have the surgeon work in the emergency department. No, we'll have the obstetrician work in the emergency department. No, we'll have an emergency doctor from Toronto work in a rural emergency department where the care is different.
It is a different world with different needs, and you always need people who understand that and understand the community context as well.
We have some questions in chat that have been sent by Sage. One of them is, what tools exist to promote the attraction and retention of healthcare workers to rural communities? And if this is a workforce issue? Yes, it's a workforce issue. I would put retention first rather than recruitment, because we need to retain the institutional knowledge and the teachers that we have. And so Dr. Sarah Newberry gave a wonderful Gateway lecture, and I would refer to that lecture that can give you a half an hour's worth of explanation on how we need to retain and recruit healthcare professionals of all types to the rural areas to address that. So I'm not going to go into details on that because we already have Sarah Newberry. She's an expert and knows more about this than I do. The other question is, what tools can you gain as a skeptic? Oh, geez, now I already like that question. To identify something that is a zombie myth. First of all, if they are walking with their arms out like this and going, "Bah," and they want to eat brains, that may be your first clue that it's a zombie myth. But when you see stuff about solutions and they say, well, what we need is to expand the scope of practice for pharmacists, and they say that it'll solve crowding, I would separate and be skeptical and say, hey, you know, like, what's the evidence for pharmacists seeing primary care problems? And is it good evidence? And if it is, we accept it. Once we have good evidence to accept a claim, we accept it. But it's attaching it to the, will it solve the problem? And that's a second part. And so to be skeptical, you would say, and does it solve the problem? What evidence do you have that what you're suggesting, has it been tried before? And where? And does it apply to my rural community? And if it's been tried in Toronto and didn't work, why are we applying it in a small rural hospital in PEI? If it's been tried in a large urban hospital in Toronto, and I'm not dishing on Toronto, I'm just using that as an extreme example between Toronto and PEI. And if it has worked, oh, we need all of these EHR systems and communication systems and all that kind of stuff. And it worked, it helped in this huge hospital that's seeing 70, 80, 90,000 patients a year with multiple physicians on at the same time. Will that help Dr. Dingwell, one nurse and a ward clerk working in a hospital that's seeing 10,000 patients a year? Maybe not. It may not have external validity to their practice setting. So we would need to see good evidence that says it does.
It's also important to consider the province of the myth, right? If someone is making a claim, is this coming from someone who has consulted with healthcare professionals to identify opportunities for solutions? Have they engaged with the important stakeholders? Or is this a simplified solution that looks good on paper, but probably isn't going to hold water at the end of the day? There has been plenty of consultation. And one thing we do tend to do in our health systems is consult everything to death, as opposed to actually taking action that can
and
solve
implemented. Yeah,
exactly. So we need actual actions that involve the input of health professionals who are on the ground doing the work and understand where the problems are. It's easy to look at numbers like emergency department length of stay and decide that that's an emergency department problem when you're not considering things like home care, inpatient beds, care for recovery after being in the hospital to restore people to the ability to go home. All of these things are under-addressed when we're treating this like an emergency department problem, when we're not the problem. We're just where it's visible.
Yeah, if you have someone that's been held for, let's say, 7 days in an emergency department waiting for a mental health professional bed, right, a psychiatrist to see them, that's going to throw off your length of stay stats. You're not measuring people's length of stay in hours. You're measuring that person's length of stay in days. And if you have a smaller volume emergency department, less than 10,000, you have 2 or 3 of those episodes where somebody's staying for days waiting for a mental health bed. Your length of stay is going to look horrible because of those outliers.
Absolutely. And again, it has to be brought back to the fact that this is terrible for patients. The emergency department is the worst place to keep a patient in an acute psychiatric crisis. It is loud, it is busy, there's people everywhere all the time, and these are people who are in a great deal of distress and really do need to be treated as acutely sick as they are. But this is the worst possible place to put them.
And emergency physicians are trained to handle the hyperacute, let's say, part of that journey that patient's on, but not to address the longer term and the needs and getting them out of that crisis part of it. We've done our part. We've stabilized the patient. We're trying to get them the mental health care services they need, but we need more access to those trained professionals.
Absolutely. And I don't have the training to be the day 6 doctor. I'm the first 6 hours doctor. I have too much ADHD to be good at that part. All of us in emergency medicine, the likelihood is pretty high.
Many of us, yes.
But we're the first 6 hours specialists. We're not the doctor who should be taking care of them and providing the optimal care days down the road. We will figure it out and we'll do a good job. But this is why when we actually look at the data, patients do come to harm because of these long delays in the emergency department. It's just not the right place for them to get the care they need.
Dr. Dingwell, there is another question in the chat, and it says, where might people discover resources to understand ER or ED overcrowding or crowding in more depth? So I would point people to the Canadian Association of Emergency Physicians, who have been writing on this issue for decades. And Dr. Alan Drummond is probably the Canadian expert on this. He's a former president of CAPE, and he is quite the advocate for access to rural health care, and is a rural physician himself and a primary care physician who works in the ED. So if you go to Google and put in CAPE, C-A-E-P, you put in CAPE and crowding or overcrowding, you should find resources from them. And also in my talk, I will share my slides. My slides will be available, and you can rewatch and freeze on that one frame where I had 4 studies that went back to 2011, and it has a number of things that would touch upon those points about how can people learn more about this.
There's also, through CAPE, is the Empower, depending how you choose to pronounce it, project where they did this task force to really look at the issues facing the emergency department within a Canadian context. It's extremely comprehensive, well-researched, and I think probably one of the best overviews of this topic.
And I've just been told that there's not just a webinar chat area, just like most things, there's like multiple streams that I have to look at, check this email, that email, this. Anyways, there's a Q&A section, Dr. Dingwell, that we've been not paying attention to. So I just clicked on the Q&A and see some questions there. Do you want to grab one of those questions and I'll grab one of those questions? Okay, you're reading. First one is from Suzanne, and it is not, is it not now the time for all doctors to require the Ontario Hospital Association, OHA, to consider rehiring qualified nurses who have opted to not have the COVID shot, our province lost over 10,000 plus nurses to this mandate. So that's a lot to unpack. And I certainly wouldn't speak for the Ontario Health Association, and I wouldn't speak for all doctors. I'm happy to speak for myself. And if Kay wants to speak for herself, she can do that. These mandates, I struggle with mandates over things, but in healthcare and as a healthcare professional, we do have to abide by certain things. Like, you know, a surgeon has to wear gloves when they scrub in and operate on a patient. They don't have the, they have a privilege to work at the hospital. They don't have a right to not. Nurses are employees, so it's a bit different. And early on in the pandemic, we had a lot of unanswered questions, and people were doing the best with the information and making decisions they had at the time. And so it's really easy to look back post hoc and second guess some of the decisions that were made. I would advocate that the Ontario Hospital Association should reconsider looking at this issue based on the available evidence. Where that will fall, I don't know. I'm not sure that we lost 10,000 plus nurses to the mandate. We may have. I haven't looked into that actual statistic, but I know that we lost thousands of nurses in Ontario over the time period of COVID that didn't necessarily have to do with a mandate, but had to do with another law about pay increase. And here are these nurses on the front lines being called heroes, and then being told by the government that they'll get no pay increase, no, like danger pay. Like, I mean, these people, they were running towards the fire at the beginning of a pandemic that we didn't know very much about, and they weren't treated well. I can absolutely advocate for that, and that they need to be treated better and with respect. And I think we lost a lot of nurses. I lost nurses. They're not my nurses. We lost nurses in our department because people just walked away, and we lost institutional knowledge. Young nurses were not joining the emergency department, and nurses who had institutional knowledge were walking away sooner than they would have because of multifactorial. But one of the main problems was the way they were treated by the government with regards to funding and taking court cases. I'm not an expert in that area, but I know that I heard a lot from nurses about that. I heard more about that than I did about COVID shots, but that could be selection bias.
There's certainly been a lot of this said to varying degrees of supportability of the claims. Within healthcare, as you point out, there are a lot of requirements for how we behave, how we comport ourselves, the care we need to provide.
Hepatitis B shots I have to have. I have to show titers for my blood against various diseases. You know, there's requirements. I mean,
we have to do our TB testing. We have to do our mask fits. There are many, many, many things that healthcare professionals need to take on as part of the job, that there may be individuals who disagree with TB testing in a low latency environment like most of Canada. There may be individuals who disagree with our need to test our N95s with the Bitrex agent every couple of years. There's many things that people can disagree with, but these recommendations are made from places of needing to protect our patients, and that at the end of the day, us being able to provide this care is a privilege. And so we'll need to make choices about what we accept and what we don't accept to be able to provide that care in the environments that have set the rules that they have. And so for us to decide that we want to work in such and such a hospital, we have to agree to abide by the recommendations that they've made. Otherwise, we just don't get that privilege. But there will always be places that people can find a space for themselves if they wish to go a different direction. So no one was forced to do these things, whether they liked it or not. It was, you may make choice A or you may make choice B. If you wish to continue in the hospital, choice A is what's recommended. But
Well, it
That's
wasn't
ultimately,
recommended.
in the end of the day,
It was mandatory,
required
right?
for
It
the
was a
hospital.
requirement. And that's, you know, I do struggle with mandatory sometimes, but mandatory is required sometimes. And especially in times where we don't know, or we may not have we have limited information. We're trying to put patients first and protect patients. And as professionals, we've come in taking oaths and things like that and trying to put patients at the center of our decision making. And if the best evidence, even if it's low level, weak evidence, is that I should take a vaccine and not be a vector for disease and and infect a vulnerable patient population who's seeking care, not seeking me to cause a problem, then we make a decision, like you said, and that decision has consequences. I can either decide based on my assessment of the potential benefits of what they're suggesting and the potential harms of what they're suggesting, and then for me go, yeah, it's not right for me and for my health, and that has consequences, so I can't work in the hospital. Or I go, nope, I'm convinced by the evidence, even if it's weak or low level, and I really want to work in the hospital, and I understand that there might be some harm to me, but I'm going to put patients first, and I want to be in the hospital. I get that, right? And then we have knowledge that evolves. And now we can look back, like I said, sure, Ontario Hospital Association should look at the evidence and go, how good is it now?
Yeah, and recommendations shift over time based on,
Yeah.
as you point out, the available evidence. These aren't static things that don't change, but we always do make the best decisions we can at the time.
With the
And
information
as
we
health,
have. Yep.
absolutely. And as health professionals, our primary responsibility is our patients.
So we have I don't know how much time they want us to wind down here. We've got 8 minutes left, and it says there's a question by James, and he says, great summary. Well, thanks, James. That comment started off well. We've seen every department, all of these things in every department, these zombic solutions. So many of these approaches are due to the perverse incentives such as PIA. Is that physician... like time to first physician access time and CTAS criteria? I think the PIA probably addresses that. How do we generate appropriate funding mechanisms inside and outside the ED and in the community? Great question. How do we put in control systems? And so when they tied funding to CTAS scores, that introduced a bias. So my first suggestion would be uncouple funding from CTAS scores. Triage patients based on their needs, based on their severity of illness, and it should have nothing to do with how much I get paid. It just means that's how sick they are. It's at the front desk. The triage nurse, who's trained individual, should not have that bias introduced by an administrator coming down and saying, well, I think you should make these people look a little sicker because we get more funding. There is a bias to push towards that in certain volume hospitals in certain situations. So my very first suggestion would be uncouple pay from CTAS scoring. What do you have? Anything?
No, I agree. Goodhart's law, right? When you make a measure a target, it ceases to be a good measure. So while we do need to track our CTAS times the importance of understanding what resources our hospitals need, hospital funding should not be tied to this. It causes issues between hospitals. It causes issues within hospitals. I completely agree that sort of metric should not be part of the funding model.
And then the pay for performance, if you have a certain CTAS standard that you're using and you find that you're upcoding, so you're not meeting the standards because the standards are like, oh, you got to see them in 15 minutes because we're now making more patients look like they need to be seen within 15 minutes. Now we're not meeting that metric. So why don't we just put a doctor in triage and say, hi, welcome to the emergency department. And then you meet all those CTAS standards, but we don't have 2 doctors in most rural departments. And so it's not possible solution in a rural area. And I would say, again, that is a control system that was put in to, again, is it Goodhart's law? Goodhart's
law, yeah.
Yeah, to try to meet that metric and game the system rather than, hey, we should be putting patients at the center of our care and our decision making, and the funding is secondary. We need to first meet the needs and then decide how can we have the funding to meet the needs of the patient, not how can we get the funding first and then do it. It's reverse.
And we need to be careful not to interpret that fast care is better care, right? So it's important not to prioritize the things that you don't want to be prioritizing. You don't want to encourage physicians to pick up all the 5-minute patients and leave the patient with the psychiatric distress because they're going to take more time.
Yeah, it's going to take an hour, to sort that out. And a sore throat might take 5 to 10 minutes. And you're incentivizing people and administrators and funders and all that stuff to see these non-urgent problems. And I don't mean they're not problems at all. The patient has a concern about a sore throat. They should be seen, but we shouldn't incentivize that away from seeing a patient who needs a new hip, or not a new hip, a fix their broken hip.
The one thing
And he's given me the hand.
We didn't say at the beginning was when I come on the screen, time to wrap up. So Kay and Ken, would you each like about 20 seconds to give any final thoughts? Kay, go first.
For sure. I saw there had been a note about someone requesting some information on rural rotations. Apologies, I can't get to that. But no, I think the real takeaway here is that we have to be careful that the information we're using to make decisions involves clinicians, has a true understanding of what the problem is, and really focuses on the unique needs of rural communities. Our needs are different from cities. We cannot take the solutions that work in one place and apply them to ours. We really have to ensure that we're not falling for those zombie myths and trying to push solutions that have no real hope of solving the problems that we're facing.
Dan, I don't need 20 seconds. I need 5. Ready?
Oh,
Stop believing in the zombies and fix the problem.
Let's
Good summary.
Let's hope that the message you are both delivering is being heard by the right people. First of all, so this is my wrap up. I want to thank both of you, Dr. Kay and Dr. Ken. This has been very educational for me, and I'm sure our listening audience, and it's been very entertaining. You're both wonderful speakers. So just a very knowledgeable and educational hour that we have enjoyed. Thank you very much. It's been great. And a little scary, Ken. So thank you for the zombie motif.
Wrong holiday.
Without our sponsors, this wouldn't happen. These lectures wouldn't happen. So we want to thank them. And they include McGee Motors in Goderich, Hurontel, Lighthouse Money Management in Goderich, DeJager Town Square IDA Pharmacy in Goderich, Zehrs Store in Goderich, CIBC Wealth Management, Libro Credit Union, and Tuckersmith Telecommunications. Gateway is a not-for-profit organization with charitable status, and we greatly appreciate and welcome any support that we receive. And when I say support, I mean financial support. If you would like to donate, check out our website and push the donate button. Our next lecture will be on May 6th at 12 noon, and the topic is One Health. It's a new concept that's gaining strength. It recognizes the intersectionality of animal health, human health, and environmental health. So thank you again, Dr. Kay and Dr. Ken. It was great to see you. Thank you to our sponsors, and thank you to our audience for tuning in. We'll see you next time. Bye for now.